early career researcher in the summer. He's a medical anthropologist who's based in the Institute for Arabic and Islamic Studies and working on, or at least kind of starting work on, a project on drug addiction and de-addiction in India. But this paper is actually going to be based on previous work, although you will see a seamless kind of connection between the previous work and the work that he's going to be doing. He comes to us from King's College London and worked on both kind of oncology organisation and morphine in India. And the original title was something slightly different. It definitely had Morphine, a Pharmaceutical, but this time we're going to do Morphine, a Pharmaceutical, Understanding the Circulations of an Absent Drug in North India. Nick.
And probably the initial title that I submitted is probably more accurate. This one it's a front page taken from a presentation already done. So I didn't actually notice that it would come back in time with the title, but that's fine. It's really the morphine of pharmaceutical question mark is the key question, and as mentioned, it will be this is mostly from the previous projects I've been working on, but yeah, as Rebecca mentioned, is work that I should build on in this new project, even if it's hopefully not going to be stuff I'm going to be working on for too much longer. But we'll see, I suppose. So I've been trying to write up this project into a book manuscript. So I thought I'd use the seminar to go over some of the key arguments, but also to set out how the book will be structured, in part to see if it feels coherent and to get a sense of how it lands. And thank you, Rebecca, for mentioning that the work sort of falls at the intersection of medical anthropology and global health, as we're quite an interdisciplinary group. So as the title suggests, this work has been around the use, or rather the lack of use, of the drug morphine, particularly in North India, and also particularly in the context of cancer care, where oral morphine is most commonly used. So just as a quick background about why to kind of look at this example at all, why to think about morphine in India. Morphine is commonly known as an opioid analgesic, particularly associated with palliative care. And as various people have pointed out, not least Julie Livingston, who some people might have read in relation to Botswana, or Dwipian Banerjee, writing about India, and again, both of them writing about cancer. Morphine is a drug that can be extremely difficult for many people to access in many different places. And this is very much the case in India, where a 2009 Human Rights Watch report put the amount of people able to access morphine at a time of need at about 4%. What is particular about India is that it's historically cultivated, and still does, a large quantity of legal opium for explicitly pharmaceutical purposes. India has a huge and highly advanced pharmaceutical industry, but morphine, a drug made from opium and labelled gold standard in pain relief by the WHO, remains very hard to access. So the early motivating question for this work was why, in a context in which the materials for producing the drug are plentiful, is it so rarely used? And I've highlighted there on the slide the states where opium is grown, which, as you can see, are clustered in the north of the country. So one of the first things I set about doing was trying to understand the circulations of this drug, because very often, particularly in public health or global health journals, researchers framed the problem of morphine as being one of a fairly straightforward absence. But as we know, it is produced in India. The cultivated opium is refined in government opium and alkaloid factories before these intermediate compounds are then sold to pharmaceutical companies for further use in medicine manufacture. Preliminary discussions with clinicians and palliative care advocates within India indicated that it was therefore more a question of highly specific circulations. Oral morphine produced by these licensed companies is purchased directly and only by specific licensed hospitals. As I've mentioned, it's very, very closely associated with cancer care. And within these settings, it's more particular, primarily given only at very advanced stages of disease. So given this, it became important to situate this work within a cancer hospital rather than a more general, sort of a general medical facility or medical college. So the arguments that I want to make are based on roughly 10 months ethnographic fieldwork undertaken between 2019 and 2022, the majority of which took place around a regional cancer hospital in a moderately sized North Indian city. This was one of a limited number of tertiary care centres in the state and the largest and most established cancer centre. Primary and secondary hospitals are dispersed more broadly, but it's only in these large tertiary institutions that staff are frequently required to make decisions about when to prescribe morphine and to whom. So this entailed working primarily with doctors, but also government regulators and pharmaceutical company representatives, alongside conducting ethnographic observation in the hospital. Alongside that, I formally interviewed members of each group, collecting data on their personal roles, the ways in which they professionally interact with morphine, or, as was often the case, do not, and the discourses and material practices they employed around the drug. This is very much an analysis of morphine within the professional domain, as opposed to one which centres, for example, patient experience or something more along those lines. So to get straight to the substance of this work, I wanted to begin with several empirical examples from this research. Maybe I have one behind. So as many scholars, for example, Kaushik Sundarajan or Stefan X, both of whom are anthropologists writing about drugs, they have noted that pharmaceuticals are ubiquitous in India. From small stalls on street sides to sparkling purpose-built pharmacies in modern hospitals, vendors selling a vast array of branded and generic drugs to be found all across the country. Because of this, visiting the pharmacy attached to the cancer hospital was an early move of mine in the exploratory first weeks of the fieldwork. Finding it empty, I walked up to the thick plastic screen that separated the shelves of medicines and boxes and vials from the general public. Two pharmacists were also behind this window, one perched on an office chair, the other leaning against the counter. The conversation that followed didn't get me any closer to the opiate medicine that I was seeking, but their words did foreshadow a different attribution of this object. The pharmacists patiently explained the different medicines stocked in their pharmacy. Most were directly related to cancer, analgesics or chemotherapeutic agents, as they were only a few meters from the door of the chemotherapy ward. It had been a typically busy morning with around 100 patients receiving treatment. I clarified the precise nature of my research and my interest in morphine. "We don't have morphine here," came the reply. "It's a narcotic drug. It's just in the cancer centre." "It's prescribed directly by the doctors," the pharmacist added, and I asked why that was. "It's a narcotic drug. We have paracetamol and tramadol." I mentioned that I thought tramadol was made from opium and therefore might also fit this category. But the pharmacists responded in the negative and reaffirmed morphine's apparent difference. Morphine is a narcotic drug. I wondered whether they had ever been able to prescribe it, and they confirmed that they hadn't. "But we have schemes for medicines," I was told. "Cancer medicines are reduced by 70 to 80%, and the tramadol, 15 tablets, should be 185 rupees, but here we sell them for only 110. They helped through two government-funded initiatives, the Ayushman Bharat scheme and a local healthcare scheme specific to the state. Both are beneficial for poorer patients, the pharmacist explained. Morphine is a CNS stimulant, they added. Avoid narcotics. Cocaine, morphine, heroin, ganja, chitta, all are abused here. And chitta refers to the plurality of substances, really, but most commonly refers to something that contains heroin, often cut with something else, antihistamines, for example. So moving from the pharmacy, the corridors of the hospital are very busy places. Prospective patients wait for their time to see the doctors in the outpatient department. Attendants look to get pieces of paper signed on behalf of sick relatives. Doctors and nurses rush from one assignment to the next. Representatives of pharmaceutical companies linger, hoping to secure an order for their latest products. Several months into my fieldwork, I fell into conversation with a pair promoting a new immunity-boosting drug. The more vocal of the two remarked that after cancer, patients often have very weak immune systems. "Our drug improves that immunity," he explained, slipping easily into sales patter. I asked them what the pharmaceutical market was like in India. Very good, he replied, growing by 30% per year. Mentioning that my project was about opiates, his companion became more animated and leant over. They are banned here, he said, waving his hand dismissively and shaking his head. No, they're not used here. Satisfied he'd made his point, he leant back and the photograph took over again. Maybe in medicines for headache, he said in a more conciliatory tone, but 0.01%. Once they'd moved into one of the doctor's offices, another rep started to talk to me, this time from a large company based in Hyderabad, so South India. His work concerned targeted cancer drugs, but he was also knowledgeable on India's cultivation of illicit opium for medical products. Not as much as Afghanistan and Pakistan, though, he remarked. Of morphine, he told me that it was not something his company was manufacturing. You can do so only with a license, he continued. Otherwise, the punishment is high. You can go to prison. Several months later, I visited a palliative care organisation in South India. In a small lecture room beside the main foyer, a trainee pharmacist from the US loaded a talk onto the computer. He began his presentation by stating that tramadol is an opioid, but that in the US at least, it's rarely treated as such and is prescribed relatively freely. As I'd seen in the pharmacy, immediate release tablets were available and similarly used in Northern India. After moving through the pharmacodynamics of the compound, he displayed the ubiquitous WHO analgesic ladder, which is a stepwise approach to addressing pain that moves from non-steroidal anti-inflammatories to weak opioids and then strong opioids. And this was something that had been described by pretty much all of the doctors who I had interacted with within the cancer centre. But tramadol, he said, this often occupies the second rung, weak opioids. But what should be considered weak? He asked us to do a small calculation between relative amounts of tramadol versus morphine. 50 milligrams of tramadol is apparently equivalent to 12.5 milligrams of morphine. And this brought us to the climactic question of the talk. Why not use a low dose of morphine as a step 2 instead? The reasoning for this was given. Tramadol must be metabolized to become an active opioid. The efficiency of metabolism is variable between people. If a patient lacks the enzyme cytochrome P450, tramadol is not converted. So, his argument went, why not use a low dose of morphine as a step 2 analgesic instead? That way you always know how much opioid has been administered. The presentation was followed by a question and answer session, during which one of the students stood to raise a point. Morphine is more regulated than tramadol, she said. Why would a physician go for the more regulated option over the one with less regulation? So as I've mentioned, studies of morphine use tend to take as given the absence of the drug from contexts like North India. At first glance, this assumption was not challenged by these interactions. The drug couldn't be found on the shelves of the pharmacy that I visited, nor in many other similar sites around the state. In a straightforward way, morphine is thus largely absent. Morphine is dispensed only from certain hospitals, those often large government tertiary hospitals with hard-to-acquire licenses. But even within these institutions, it's kept distinctly separate from the rest of the pharmaceuticals. It's not stored in the pharmacies or even dispensed from them. Its flows within the hospital are different. It exists under lock and key in specific cupboards overseen by specific people, and it's strongly associated with cancer. Knowledge of the drug was also denied by the brevity of my interlocutor's answers, cut off immediately after the apparent self-evident status of morphine had been uttered. But the drug is nevertheless also present. It was there in the medical bags that certain patients carried with them when they entered the pharmacy from the cancer hospital, only a few feet down the corridor. It was there in the oppositional definitions given by the pharmacists towards the drug that they do stock, or the pharmaceutical reps towards the drugs that they sell, morphine as a narcotic, tramadol as a pharmaceutical. There in the allusion to criminality and abuse that were included in their answers. So on closer inspection, these interactions, I suggest, reveal morphine's presence as much as its absence in such a medical space. It's a slippery object of research, fading between categories such as therapeutic and danger, legal and illegal, as the pharmaceutical representatives demonstrated through their invocation of Afghanistan and Pakistan, supposed major sources of the illicit opiates in India. So as the project advanced, the questions moved beyond approaching morphine in the sense of an absolute lack. It's undeniable that the material movements of this particular object, this small pill, are subjected to restriction with a high degree of success. But as this occurs, its symbolic circulations are widespread. For the regulators who worry about expanding access and its potential diversion, it carries the threat of the illicit. For palliative care advocates working to increase access, it's a vital therapeutic. For patients receiving it only after all curative therapies have been halted, it is a death sentence. For the companies that do not produce it, fearing the reputational damage that doing so could cause, it's a financial liability. Morphine is therefore made a heterogeneous and multiple object. An early discussion with the hospital's palliative care doctor demonstrated this clearly. Without morphine, he remarked, we are handicapped, yet it is a last resort. When nothing will act, it will surely act on the pain. With morphine, you can say I've got everything to take care of pain. It is a wonderful drug. But the wondrous nature of this substance brings with it the need for care. I only give 15 pills at a time, he cautioned, in case they end up with inappropriate people. There is a lot of addiction in India. Morphine is great, the best painkiller, but it has this risk. So this takes us beyond an assumption of a drug as a unified entity, stable through processes of production, distribution, and consumption, or something easily assigned a normative position, good or bad, licit or illicit. And the multiplicity of opioids has been demonstrated in other contexts. We have, Maziar in the Institute, through his work around opium in Iran, is another example, or Tim Rhodes working at LSHTM around methadone. But while there are many ways morphine could be classified as licit or illicit, as a medicine, an analgesic, an opiate, an opioid, as top rung on the WHO analgesic ladder, as a gold standard in pain relief, I suggest that in this instance, there nevertheless persists an anchoring category that overshadows these other possible attributions. In the pharmacy and in the hospital corridors, these were not the classifications invoked. Instead, the specific concept immediately called upon was that of morphine as a narcotic. It was primarily grouped not with tramadol, buprenorphine, or other medicines lining pharmacy walls, but instead with those sought not by medicine, but by law enforcement: cocaine, heroin, marijuana, and chitta. And the effects of this can be seen in the rejection of the drug within aspects of the medical community. As a doctor in a palliative care organisation in Delhi remarked in an interview, we've had patients who are physicians themselves who would not want to take it. I mean, they would take tapentadol, a strong opioid, albeit step 2 on the WHO analgesic ladder, but they will not take morphine. So there are these perceptions. One is about respiratory depression and one is about addiction. They won't take it. The broad interventions that I want this work to make are twofold. In the first instance, it pushes the recognition that morphine is characterized as much by its presence through its symbolic imaginations, as well as alternate material forms, such as those produced within pharmaceutical manufacturing that I'll discuss shortly, as by its absence in the North Indian context. If we accept the argument from much recent work in the anthropology of drugs, that they are objects with multiple possible attributions, I further suggest that in the case of morphine, it does not carry primarily pharmaceutical signification. What happens to an object is highly dependent on its classification, and in the case of morphine, I argue that its dominant attribution is in fact that of the narcotic. So the term narcotic plays a highly important role in the organising of medical and public interactions with morphine, as well as other drugs, remaining a central reference for those involved in law and medicine, but also regulators, pharmaceutical representatives, and members of the public. But as a legal and medical term, the narcotic isn't particularly well described or defined. Legislatively speaking, a narcotic drug is defined in India as coca leaf, cannabis, opium, poppy straw, and includes all manufactured drugs. But this latter category, that of a manufactured drug, comprises of all coca derivatives, medicinal cannabis, opium derivatives, and poppy straw concentrate, as well as any other narcotic substance or preparation which the central government may declare to be a manufactured drug. So given this slightly circular definition, the exact boundaries of the term are unclear. In practice, the usage seems to roughly follow that of the very specific list of narcotic drugs under international control, compiled by the International Narcotics Control Board, which includes opium and morphine, as well as fentanyl and oxycodone, but does not include notionally weaker opioids, such as tramadol or tapentadol. Unlike for many pharmaceuticals in India, laws preventing the possession and distribution of narcotics are strictly enforced, and arrests for contravening them are frequent. In the first instance, this marks them as distinct within the wider pharmaceutical context. Most pharmaceuticals are very easily available, unregulated, and widely consumed. Pharmaceutical companies trade directly with hospitals and pharmacies, and many different types of drugs move freely around populations. So this is a picture of widespread and largely unregulated pharmaceutical stocking, selling, and consumption, including from those without licenses to distribute allopathic drugs. So the most common drug categories involved are mild analgesics and antibiotics. But as the work of Sumita Basu and Stefan X have shown, this also includes more highly restricted drugs, such as psychopharmaceuticals. This widespread illicit movement of drugs is an open secret. Doctors share their knowledge with informal medical providers. Wholesale medicine retailers sell to them, and licensed medical outlets meet the notionally illicit prescriptions that they write. So this is a tolerance of illegality that is in striking contrast to the approach taken with morphine. As the pharmacists explained, the drug is classified as a narcotic and therefore is subjected to a level of control and regulation most allopathic drugs are not. But there must also be specificity to the argument, because legislatively speaking, morphine remains a narcotic, but so too do many other similar drugs, stronger opioids such as fentanyl, for example. But they're not always configured in the same manner. Of fentanyl, despite its apparent strength, it's significantly stronger than morphine. Our interlocutors indicated that where it was available, and this is mostly in private practice, it's more readily consumed. So a key focus must therefore be on how practices around morphine maintain its primary narcotic signification, while other similar substances are rendered more readily as primarily therapeutic pharmaceutical objects. So this picture is a good example, and it's from a friend of mine, Dr. Nishanth Kunakatal Shaji, who's been studying palliative care, particularly in Kerala in South India, and hopefully he'll visit us here in April. But he sent me this picture and finally said I could use it today. So in contrast to the description of morphine that we've heard, it shows fentanyl being actively advertised by the pharmaceutical Verve at the Indian Association of Palliative Care conference in 2023. So this is kind of the main thrust of the book's argument, and I intend to, for the chapters, to examine both how this situation has emerged, but then how it's subsequently maintained. So to be specific, how the category of narcotic has gained its salience, and why morphine in particular, rather than other similar objects, signifies this concept such that its material restriction becomes necessary. So I'll quickly use the time remaining just to give an overview of the proposed structure of the chapters. If we can get there. So key to this regulation is the 1985 Narcotic Drugs and Psychotropic Substances Act, and this will be the subject of the initial chapter. So while anti-drug legislation of the 1950s and 1960s tried to limit the circulation of opium and opiates to science and medicine, this newer act impacted practices within those fields. It required registered medical practices to obtain up to 5 licenses in order to stock the medicine, without which practitioners would run the risk of a heavy fine or imprisonment. And as noted by those working within the palliative care movement, hospitals and pharmacies subsequently stopped procuring and stocking morphine because of the burdensome licensing process and the fear of prosecution that might result from bureaucratic or accountancy mistakes. This act was in part designed to meet India's international obligations as a signatory of the 1961 UN Single Convention on Narcotic Drugs. But as historians such as Anirudh Deshpande have argued, this restrictive legislation that governed access to opium in India after independence was formulated in deliberate contrast to that of the colonial era. So this chapter demonstrates how the changes in law were rooted in medical and political thinking, not just of the colonialists, but also the positions taken in opposition to opium within the anti-colonial movement. So we can see the 1985 NDPS Act and the subsequent decline in morphine use, not just as a moment of dissolution and change, but also as a piece of regulatory intervention that carries with it a medical and social history of factors such as agricultural reorganization towards opium, anti-colonial activism, as well as racialized ideas of vulnerability. The Narcotics Acts, with their colonial origins, alongside contemporary narratives of addiction with their own localized contours, which are examined in the second chapter, set a legislative stage for the restriction of drugs more broadly. So with this as a grounding, subsequent chapters set out to show how this focuses on morphine in particular. So its limitation is in part derived from the highly commercialized and competitive environment that since India's economic liberalization in the 1990s has come to define its healthcare landscape. And this is the subject of the third chapter. This transformation, set in motion in earnest by the Congress-led government in 1991, has manifested itself in the turning over of responsibility for healthcare to the market. New corporate hospitals, imagined as the sites of the most advanced care and sort of emblematic of modernity in Indian healthcare, they deliberately invest in specialities that deliver high success rates for often very specific procedures, preferably those with quick patient turnover that generate maximum income. Palliative care, the primary site of morphine use, is quite far down the list of investment priorities. And where opioids are prescribed in the private sector, the drugs that are offered are specifically chosen. Instead of the extremely cheap stocks of oral morphine held in certain public hospitals, in private hospitals, it's more likely that the various opioids dispensed are in the form of patches, be these buprenorphine patches, which is an opiate considered less strong than morphine, or fentanyl patches, which, as I've mentioned, is considered stronger. The reason for this, as one private doctor explained, is simply because they're relatively expensive. As he neatly summarized, at the end, when you're in the private sector or you are a manufacturing concern, you have to look at your profitability. That's what it is. Morphine is a drug with little profit potential and is therefore relegated to large government hospitals, themselves often associated with advanced disease and overburdened services. So these commercial logics equally implicate the manufacture of different opioids. I've mentioned the paradox of morphine's production but low use. It is a drug widely produced in the country. In 2020, manufacturers produced almost 13 tons. But given the highly commercialized nature of Indian healthcare and pharmaceutical manufacture, the vast majority is further refined into other downstream opioids, differently marked and subjected to less stringent regulatory oversight. In the years 2018 to 2020, the proportion of manufactured morphine that was actually consumed as morphine was only 3.1%, 1.7%, and 2.6%. You can see this for both recent years, but also further back on the slide, coming at the blue bar being the amount manufactured, the orange was used in producing other opioids, and the green was actually consumed as morphine, if you like. So again, we can see a manner in which morphine sort of both is and is not present in this context. So to move then from the level of production to follow oral morphine purchased generally means following it to a cancer hospital. As many scholars such as Cecilia Van Hollen or Dwaipan Banerjee have demonstrated, cancer is a disease with particular connotations in India. It's a condition that, through the structural limitations that often ensure its late diagnosis or treatment, has for many people gained associations with pain, disfigurement, financial ruin, and death. It's significant then that morphine, through the logics of private care, has been largely relegated to government cancer hospitals. But even here, as indicated in my interactions in the pharmacy, the drug is kept quite separate from the pharmaceuticals more widely used. Instead, following it entails making highly specific moves throughout the hospital, its passage disciplined by rigid adherence to procedure intended to ensure its complete absence away from this particular pathway. On several occasions, this procedure was shown to me in the subject, and it will be the subject of the fourth chapter. Once procured from a selected pharmaceutical company, the quantity of morphine in the hospital's possession is physically verified before it's stored in a specific cupboard unlockable by only one key. Small quantities are then moved from this cupboard into a second lockable cupboard in a different room from where it's prescribed. Records defined by dates and signatures are made at each juncture, and a logbook of each patient to whom morphine is given, for what reason and in what quantity is carefully maintained. This is one of my favourite images from field work on the left. One of the senior oncologists digging out stocks of morphine from the cupboard in the head of the hospital's office. And on the right is the prescription logbook. Procedures and documents such as these are generative. They don't just record, but they also have the capacity to bring things into existence. And every small piece of documentation that refers to morphine is stored in these carefully maintained files. The head of the cancer centre was appointed an administrator, in part to maintain these records. The request letters are kept, the quantities purchased are logged, their safe arrival is verified, and these verifications are themselves carefully stored. So all of this bureaucratic work contributes to the sense of danger that pervades this object. Even the most casual observer would recognise the amount of written work given over to this single drug must mark it as somehow different. The record books, files, letters, stamps, and signatures all serve to further reiterate and substantiate morphine's status as a narcotic, its association with danger of addiction or death. So through its absence in more commercial settings, morphine gains its association with cancer hospitals, particularly those run by the state, and so concurrently with notions of terminal disease and decline. Through its heavily bureaucratized and controlled appearances within these institutions, its status is further marked. In part because of this, it's become a drug never used by the majority of allopathic doctors working within the healthcare system. Doctors I interviewed disagreed about whether or not it had made an appearance during their studies in medical school, but agreed that once they had qualified, they would never see it used. The exception, as I've indicated, is within large tertiary hospitals that explicitly set out to treat cancer. But even here, in part because of the significations that I'm describing, it's gained a particular temporality. As a senior physician in the hospital remarked during a conference on pain and palliative care held at the hospital in autumn of 2019, we used to be reluctant to prescribe morphine, especially during the disease process. We used to think morphine is for end-of-life care. More educated people, that speck of thought immediately comes. My patient has been put on morphine. It means he or she may be terminally ill. If I can avoid putting a patient on morphine, I will, as at times they just put it back. So doctors know that pain brings people to the hospital. They ask questions about it, acknowledge the pain that's described when taking histories, note that which is expressed in the flinches of their patients when they conduct physical examinations. But nevertheless, as indicated in this statement, a drug like morphine has typically been reserved only for those for whom curative treatment has been halted. In conjunction with the rare material appearances of morphine that I've described, the fact that where it is used, it is often withheld until late-stage disease, inscribes upon morphine a temporal symbolism that further renders it deeply alarming. This practice serves to construct a temporal imagination of morphine that's equivalent to a death sentence. So in this fifth and final chapter, I therefore draw on anthropological analyses of prognostic and diagnostic disclosure in India to suggest that within the outpatient departments of the hospital, where disclosure is often partial and indirect, morphine can play a communicative role, communicating what neither a doctor wants to admit nor a patient wants to hear. So to draw this to a close, in making the argument morphine is not absent in the manner typically assumed, I've been conceptually marking its material and symbolic circulations, the former heavily restricted but the latter simultaneously abundant. Morphine is well known, but it's important to recognise a third thread within the analysis, because there are also parallel or alternate circulations of opiates occurring, flows that at times escape the rigid oversight and control. Industrial morphine is transformed into codeine and circulates in the form of cough syrups. In another example I haven't had time to go into, opium freely circulates in certain Ayurvedic therapies in concentrations that would in allopathic medicines mark them as restricted. In a sense, morphine both is and is not present, determined by the ways in which it's classified. So the key question that's been presented, or presented itself really throughout, is that how is it that morphine maintains its narcotic signification when for other drugs that could be similarly defined, it falls away? The narcotic is not a stable category consistently invoked. Why, for example, are pharmacists more ready to dispense tramadol or buprenorphine? Why do private patients accept fentanyl patches but refuse oral morphine? Why do doctors, when receiving treatment for their own cancers, hide their pain so as not to be given morphine, yet accept tapentadol? Each of these drugs are opioids and hence could be categorized as narcotics, although typically tapentadol is not. But even among definitionally secure narcotics, subsequent practices don't always adhere to the boundaries of that legal definition. Morphine is termed a narcotic with all the medical power, legal and punitive connotations and hesitancy to prescribe and consume therein. But fentanyl, a synthetic opioid legally secure in this definition, is socially configured more readily as a pharmaceutical, in part through its position as a revenue generator within private healthcare. And as we saw in one instance through the advertisement in medical conferences. So the initial 2 chapters try to display how the broader category of the narcotic substance kind of emerged as a locus of fear and subsequent control. But in the latter sections on clinical decisions and performances of bureaucratic accountability, we've seen how practices, bureaucratic, economic and medical, assure this particular attribution is maintained around morphine, when for other similar drugs, repeatedly mentioning tapentadol, tramadol, both of which are readily distributed at reduced rates, this potential categorization falls away. These commercial logics, material practices, and documents collectively render the drug's material absence necessary. As a very final point, there are, of course, regional variations in this process. Morphine is not anchored in this way everywhere. Kerala, the home of the Indian palliative care movement, has around 180 palliative care centres, and morphine is more easily procured. Through work conducted at the level of state administration and through strong community engagement, these groups have been very effective in rendering the drug primarily a therapeutic pharmaceutical object. So what this shows is that narcotics, or any drugs for that matter, are made as much by the practices around them as by the precise boundaries of legal definition. Returning to my North Indian field site, tramadol, tapentadol, or codeine are not marked in the same way as morphine. They're not subjected to separate systems of storage and distribution, withheld until the last stages of terminal disease, kept absent from all medical practice but oncology and all practitioners but doctors, nor are they given a temporality that binds them to incurable decline and death. So through the practices, discourses, and documents around it, the status of morphine as a narcotic is repeated and consolidated. Through these processes, morphine's narcotic significations are established and maintained, and positioned in ascendance relative to other ways of imagining the drug. Stop there.
Indeed. Do indeed love that picture. the highly sophisticated morphine. Anyway, people online, if you want to either put your virtual or actual hand up in the chat, please do. Anyway, questions, comments? Yeah, Rosie.
Thanks, Nick. That was brilliant. I really enjoyed it. Knowing nothing about that subject at all before. I think my question is probably answered in chapter 2, but I want to ask it anyway.
Yes.
So the fear of addiction. But if morphine is so regulated, is it that there? Sorry if I missed this. Is it that there is a problem with addiction and people getting hold of it illegitimately? And if not, is the fear of addiction from some other place, the history, the West, some other people? Who are these addicted people that we're worried about becoming? That's probably chapter 2.
Yes, you're right, it is. The short answer is very, very few people, if any, are addicted to morphine.
Yeah.
It's really hard to get hold of, and the doctors know this. So to start with, to begin with, the kind of, when you talk about more, I mean, I didn't really intend to talk about addiction necessarily. I thought, it's a likelihood it'll come up, but this isn't necessarily something that's going to be front and center. But when you talk to doctors sort of in the field, you get kind of a very sort of responses that have this kind of gradation depending on where exactly they work. So people in regulatory positions, often people who've worked in sort of frontline healthcare for a while and are now in ministries of health, they will say things like, "Oh, we can't make this drug more available because addiction is everywhere." you talk to people in cancer hospitals who are prescribing morphine. So, are you worried about your patients becoming addicted? And they will say, no, of course not, because these are people who are, as I mentioned, will be covered later on in later chapters. The people who are getting the drug are so close to the ends of their lives on the whole that it's, the doctors are not concerned at all about it being used for anything other than pain relief. They know their patients are desperate for it, and that's what it will be used for. So the concern around addiction is primarily sort of regulatory level, rather than the practicing doctor level, or the people who actually use morphine. It's very much there among doctors who don't use morphine, very much doctors in other specialties. In terms of who are the addicted people, I'm still not sure about what to do about this, but I think I'm going to be much more specific than I have in this talk about exactly where in India and where in Northwest India these interactions are taking place, because it is really important. And one of the reasons it is important is because of these questions around addiction. So this, are we recording?
Yeah.
Do
you want to stop?
Where does this go once it's recorded?
We could stop. Yeah, let's stop recording.
All right. I just want to talk to my interlocutors again before making that final decision. But where are we?